Hello, and welcome to The Explainer. Today, we're taking a medical topic that sounds pretty complex, and we're going to make it simple. All right, let's kick things off with a number that might actually surprise you. 18%. On average, about 18% of people have some kind of, let's call it an abnormality, in their pituitary gland. And here's the wild part. The vast majority will never, ever even know it. And the most common of these abnormalities is something called a Rathke's Cleft Cyst. Today, we're going to demystify this condition that's way more common than you'd think. So here's our game plan. We'll start with what this common hidden cyst even is. Then we'll rewind all the way back to see how it's an embryological leftover. After that, we'll talk about the symptoms that can pop up if one starts to grow, how doctors can actually see inside to diagnose it, and then the two main paths forward, to observe or to operate. And finally, we'll cover what to expect after treatment. Okay, so an embryological leftover. To really get what a Rathke's cleft cyst is, we have to go way, way back, all the way to the very beginning of how our pituitary gland even forms. So, when we're just embryos, you've got these two different types of tissue that need to meet up. Think of it like two pieces of a puzzle coming together to create the body's master gland. And as they join, sometimes, just sometimes, a tiny little potential space, a cleft, can get left behind right where they meet. This space is called Rathke's cleft, and for some people, cells that get trapped in there can start producing fluid, and over time, a cyst forms. And this brings us to a really crucial point. A Rathke's cleft cyst, or an RCC, is benign. It is not cancerous. We're not talking about a tumor in the way you might think. It is literally just a developmental leftover. So if it's just a leftover, when does it actually become a problem? Let's talk about the symptoms. Now, for the vast majority of people, these cysts are tiny. They cause zero symptoms, and they're usually found completely by accident during an MRI for something else entirely. But if that cyst starts to grow, if it gets big enough, it can start putting pressure on all the important stuff around it, like the pituitary gland itself and the optic nerves. And that's when the symptoms can start to show up. So, what kind of symptoms are we talking about? Well, that pressure usually causes three big issues. First, you get headaches, and they can be pretty persistent. Second, you can have hormonal problems, which makes sense, right? You're squishing the body's master hormone gland. And third, you can get vision loss if the cyst pushes on the optic chiasm, which is where your optic nerves cross. Okay, so if a patient has these symptoms, how do doctors actually confirm that they're being caused by one of these cysts? How do they see what's going on? Well, the gold standard is an MRI. A detailed scan gives doctors a perfect picture of the pituitary area. That imaging lets them see the cyst's exact size and location and pinpoint exactly how it's affecting everything nearby. And here's a really cool detail. A classic thing they look for on the MRI is something called the split gland sign. You can literally see the cyst separating the two parts of the pituitary. It just perfectly illustrates that it's sitting right in that original developmental cleft you were talking about. Pretty neat, right? Of course, a big part of diagnosis is telling it apart from other things. For instance, a craniopharyngioma is another type of growth that can show up in the same area. But there are key differences. An RCSC is almost always just a simple cyst, while a craniopharyngioma often has solid parts and even calcifications. All right, so once the RCC is confirmed, the care team and the patient, well, they face a big decision. This leads us to the two paths, to treat or not to treat. So a cyst is found. What happens next? The answer really boils down to one simple question. Is the cyst causing any problems? Path number one is just observation. If the cyst isn't causing any symptoms, the standard approach is to just, well, watch it. You get regular MRI checkups to make sure nothing changes. And get this, one study found that 87% of these cysts stayed exactly the same over 2 years. Even more surprising, 10% actually got smaller on their own. So in reality, less than 10% of all people who even have a Rathke's cleft cyst will ever need surgery. Think about that. For most, it's just a harmless little quirk of their anatomy. But what about that other path? Path 2 is the surgical approach. And this is for the people who are having symptoms, the vision loss, the severe headaches. For them, surgery is the answer. The surgeon typically goes in through the nose, carefully opens and drains the cyst, removes as much of the cyst wall as is safe, and then reconstructs the area. The whole goal is just to relieve that pressure. So for that small percentage of patients who do need surgery, what can they expect after? What do the outcomes look like?
Honestly, the results are usually excellent. I mean, look at these numbers. Studies show that vision improves for 100% of patients, headaches resolve for 88%, and hormonal issues get better for 83%. Those are really, really good outcomes.
But what about it coming back? That's a natural question, right? Well, while a scan down the road might show a tiny remnant, the chance of it growing back and causing symptoms all over again is actually pretty low, only around 8 to 10%. So in the end, the story of the Rathke's cleft cyst is a really positive one. It's a common remnant of our past that's effectively managed with modern science. It's a great example of understanding something and knowing exactly when to act and when not to. Which kind of makes you wonder, doesn't it? How many other harmless little artifacts of our development might we be carrying around with us, completely unaware? It's a fascinating thought. Thanks for joining this explainer.